We have Dr. Sethi joining us today, and I'm so excited about this conversation about GERD treatment prevention. So Dr. Sethi is a board-certified gastroenterologist. He practices in Fremont, California, which is actually very near me in San Francisco, California. He received his gastroenterology training from Harvard and Stanford. And so why don't we start by just talking about the common causes of GERD?
Sure. Acid reflux is primarily caused by a weakening of the lower esophageal sphincter, which normally acts as a valve between the food pipe and the stomach and prevents the acid produced in the stomach come up and hit the food pipe. And there are some common reasons why that can happen. One of the very common reasons is if a person is overweight or obese, that can put pressure on the stomach, and that can cause the acid in the stomach to come up and hit the food pipe, leading to acid reflux. The other reason would be hiatal hernia. People who smoke or drink a lot of alcohol, they can also suffer from persistent acid reflux, because both of these actually relax the lower esophageal sphincter and make symptoms of acid reflux worse. There are certain foods and beverages that can cause worsening of acid reflux. So can some of the commonly prescribed medications. For example, one of the medications for high blood pressure called calcium channel blockers, they can decrease the pressure of this sphincter and make symptoms of acid reflux worse.
Yeah, absolutely. And I would also add to that, just as a dietitian, something I see all the time is kind of like food habits, like people who are eating really late at night, or shift workers maybe, where they can only have like one large meal late at night. I see that a lot too. I'd also love to talk about testing options for GERD. So what kind of tests should people be asking their medical providers for?
There are four most common modalities that we use when we're dealing with acid reflux. The first one would be doing an upper endoscopy, and that would mean checking the integrity of the esophagus firsthand. So we're looking for things like Barrett's esophagus, which is considered to be a precancerous condition that can happen if someone has persistent acid reflux. Then we're looking for inflammation in the esophagus called esophagitis. We're looking for any ulcers in the food pipe with the use of endoscopy. So all of those things can be checked out with this one simple test called upper endoscopy. Then we can do esophageal pH monitoring to measure the amount of acid exposure in the food pipe. Then there are things like esophageal manometry to check the muscle function and the motility of the esophagus. Then there is a non-invasive test called barium swallow, where the person would ingest some barium contrast, and that can sometimes tell us about acid reflux, as the barium contrast starts refluxing into the food pipe as we're doing that extra
Thank you so much. I think
testing.
it's important to know that it's not just the endoscopy. If you get an unremarkable endoscopy, there are other options. And I'd love to ask you, what would you recommend for next steps for someone who has had an unremarkable endoscopy, just didn't really find anything in terms of, root causes or next steps there?
If an endoscopy, let's say, is unremarkable and the acid reflux symptoms are persisting, then the next step would be doing a motility testing to make sure the muscle of the food pipe is actually intact. We can also consider doing an impedance testing to make sure that the person is not having non-acidic reflux.
So based on that sort of approach with understanding like non-acid and acid, let's talk about treatment options for GERD and what are some of your first line treatments?
I like to start the treatment with lifestyle modifications. Even though we have medications, and in severe cases we can refer the patient for surgery if needed, but lifestyle modifications are always the primary modality as far as I'm concerned. Avoiding spices and sour foods. So spicy food would mean avoiding hot sauce, hot peppers, and sour foods would mean avoiding citrus fruits like lemon, pineapple, orange, lemon water, apple cider vinegar. They're all acidic and can make symptoms of acid reflux worse. Mint is also a very common ingredient that can cause acid reflux by lowering the pressure in the lower esophageal sphincter. I tell my patients to try and sleep on the left side, because what happens is when they're sleeping on the left side, the gravity would keep the acid in the stomach to stay in the stomach, and acid is less likely to come up and hit the food pipe if you're sleeping in the left lateral position. Ideally, there should be a gap of 3 to 4 hours between your dinner time and your sleep time, because in that window, the acid produced in the stomach would have done its digestion of the food, and all of those contents would have moved down into the small intestine, and you're basically sleeping with a kind of a clean stomach, and that will likely prevent acid reflux from happening. One more thing. I had a patient yesterday, all of these things he was doing, but there was one thing that I noted was still causing acid reflux in him. And that was the use of very tight belts. So if you're using very tight belts, that can put pressure on the stomach and can cause the acid produced in the stomach to come up and hit the food pipe. Let's say someone has done all these lifestyle modifications and they're still struggling with acid reflux. Then the next step to do is try some medications. I tell them to try using antacids or TUMS for occasional acid reflux. If the symptoms become persistent and all of these things are not helping, then we move on to things like H2 blockers, for example, famotidine, to try and decrease the acid. For severe cases of acid reflux, we have to use proton pump inhibitors, also known as PPIs, like omeprazole or pantoprazole, because these can reduce acid production and help with persistent acid reflux symptoms. In severe cases where the reflux is medically refractory, where all of these lifestyle modifications and medications have not helped a person, then we do refer them to a surgeon to get a surgery called fundoplication that tightens the lower esophageal sphincter and prevents acid reflux
That's
from
great
happening.
information. And I love that you started with the lifestyle changes, because those can go a long way. And even thinking about things like posture during meal times, like making sure you're sitting up nice and tall during a meal, having that nice flow, and making sure you're maintaining good posture after meals, and chewing your food well, making sure that you're getting that digestion process started. Those are two things that also I think can go a long way, and not overfilling the stomach. So I talk with my clients a lot about 80 to 90% fullness at meals, and trying to learn how to eat to 80% fullness and prevent getting to 110% fullness. That's a big one.
Exactly. Yeah, smaller meals are definitely advisable when it comes to acid reflux.
So a question I get a lot is, what if I'm having breakthrough symptoms on my PPI? What are some things that I should be talking to my doctor about, or what are some next steps?
That's actually a really good question, because I see that scenario very commonly in my clinical practice. People on PPIs and having breakthrough symptoms. So what do we do about it? So there are a few things we can do. One is adjusting the dosage of PPIs. Second would be switching to a different brand of PPIs. And then we can also use adjunct therapies like H2 blockers, as I mentioned before. For example, famotidine, we can add that onto their PPI therapy for short term. Eventually, with the goal of tapering these medications off, after a couple of months, once the acid reflux has healed up. Yeah, there's also acid reflux wedge you can buy off of Amazon, and it elevates the head of the bed. You can just stick it under the mattress, and a lot of my patients get immediate relief when they start using this wedge.
Can we talk about Barrett's?
Barrett's esophagus. It can happen with long-term acid reflux problem. Now, unfortunately, it's a precancerous condition. However, with regular surveillance endoscopies and effective management of acid reflux, we can prevent Barrett's esophagus from turning into esophageal cancer.
What about long-term PPI use? What are your thoughts about that?
Long-term PPI use is indicated for the right reason. Someone with Barrett's esophagus, someone with eosinophilic esophagitis or severe GERD, definitely the benefits of PPIs outweigh the risks. However, if you're having mild acid reflux and you're taking PPIs like candies, for long term, that's the time when we need to intervene and try to taper you off of these medications, because long-term PPI use is associated with risk for fractures, decreasing the magnesium levels in your body, and also having negative effects on your kidneys.
What if you just take home messages, if you could leave, some important take home sound bites for our listeners about GERD?
This is one thing I would like my listeners to take home. Two most commonly missed causes of acid reflux are lactose intolerance and H. pylori infection. Lactose intolerance affects almost 2/3 of the world. H. pylori infection affects 40% of the world. And both of these conditions can cause acid reflux. So if you're suffering from persistent acid reflux, please talk to your doctor and get these two conditions checked. Both of these conditions are easily managed. Lactose intolerance can be managed by removing the lactose from your diet. H. pylori infection can be managed by treating with antibiotics.
Awesome. And then I know everyone listening, is interested in learning more from you. So how can they best get in touch with you and learn more about you?
They can find me and follow me on Instagram at my handle, Dr.Sethi. So DOCTOR.SETHI. And I look forward to seeing you all over there.
Thank you so much, Dr. Sethi. We appreciate it so much. Thanks for sharing all this important information.